Hello, Push and Power Pregnancy family. I am just so excited to be here this morning. I'm going to just briefly talk about the relationship between racial disparities and stillbirth. I'm going to talk about the cliff of good health and how disparities actually occur, and talk a little bit about racism, chronic stress, and weathering. So first of all, we've seen a lot of data this morning, and in fact, I'm sure most of you in the audience know this data better than me, but I just want to draw your attention to 3 facts. 1, Black and Native American families experience stillbirth at twice the rate of other families in the United States. Stillbirth rates are higher in the southern states. And I want you to remember that because I'm going to come back to that in just a little bit. And 1 in every 166 deliveries ends in stillbirth. So this is just a quick snapshot of many of the risk factors associated with stillbirth that many of our speakers have already addressed this morning. I've added some yellow areas to highlight racial disparities in particular. The first point I want to make is low educational status. For white women, a lower SES educational status is associated with a higher risk for stillbirth. We don't see the same association to the same degree with Black women, and we see the same trend with preterm births, meaning a higher SES status, a higher educational attainment does not necessarily protect me from having the adverse outcome of a stillbirth. Black women have higher rates of obesity, higher BMIs associated with higher rates of stillbirth, higher rates of chronic hypertension, higher rates of diabetes, higher rates of lupus, higher rates of fibroids, higher rates of abruption, higher rates of preterm birth, and higher rates of chronic stress, all of which are associated with increased risk for stillbirths. True racial disparities. Well, personally, I don't feel like any conversation can happen about racial disparities without discussing the model for the cliff of good health. It's pretty hard to do in a short time frame, but I am up to the task. The cliff of good health was a model developed by Dr. Kamara Jones. As you guys know, disparities happen between advantaged groups and disadvantaged groups. Disparities are differences that should not be. There are several ways that disparities happen. And normally when I speak to an audience, if I ask, why do disparities happen? 90% of people will say because of differences in access to healthcare. And that is true, but that is not the only reason why disparities happen. There are 5 ways that disparities can happen. Let's talk about those. So on this cliff of good health, you see an advantaged group that is further away from the edge of the cliff, and you see a disadvantaged group that's closer to the edge of the cliff. If you've ever been near a cliff, you know you don't want to be standing by the edge. So these individuals that have more advantages have advantages for several reasons. 1, they have differences in social equity, a higher SES status, access to better resources. When you have access to better resources, you have differences in exposures and opportunities. Like what? You can live in a better neighborhood. You can go to a better school. You have access to fresh fruits and vegetables. You have access to excellent transportation. You have access to parks. Your neighborhood is safe. You don't feel discriminated there. For these individuals, they're able to stay further away from falling off the edge of the cliff of good health. And when they do have challenges, they're able to get good health care and not have to seek their health care in a tertiary care center. For our disadvantaged populations, they have less resources, less access, less social equity. When you have less social equity, you know what? You don't have the same resources and opportunities. You don't go to the same schools. You don't have access to healthcare that is better than the healthcare that we have in segregated neighborhoods. You don't have access to fresh fruits and vegetables. You don't have access to good transportation. And often you don't have access to places that are safe, even in your own neighborhood. So these are 3 ways that disparities can happen that we just discussed. Differences in resources, differences in exposures and opportunity, and differences in underlying health status. When you don't have access to the same resources, your risk for having a poor health status is higher. You may have more asthma. You may have more hypertension. You may have more diabetes. And you know what? When you have challenges, you often have to go to the ER for your primary health care. We've already talked about access, but I want to draw your attention to number 5, my personal pet peeve. If you don't remember anything else that I share with you this morning, please remember this. Access to care means nothing if once I finally have access, I do not receive the same quality of care. And unfortunately, in the United States, we know that Black patients, when they are in our healthcare systems, are subject to differences in quality of care. We know that when we complain of pain, our pain is less likely to be treated because there are those who believe we have a higher pain threshold. A study of medical students in 2016 polled, and still in 2016, medical students think that we have thicker skin so that our complaints of pain are not valid. So if I'm in front of you complaining of pain and you dismiss me, if I'm in front of you complaining of decreased kicks and you dismiss me, if I'm in front of you having already experienced 2 losses and you say, well, that's just, you're experiencing losses just because you're a Black American, guess what? I'm not gonna have the same quality of care. Access means nothing if the quality of care I receive once I'm finally in front of you is not the same. So what about these advantaged populations and these disadvantaged populations? What makes some patients further away from the cliff and closer to the cliff? Often when we talk about higher risk for chronic conditions in Black Americans or Black women, since that's my topic for today, we want to attribute it to DNA, that just by virtue of being born, my DNA, my biology has increased my risk for hypertension, diabetes, asthma, poor outcomes, and a shorter lifespan. It's just simply not true. The social determinants of health have been shown to have a greater impact on health status. 40% of our health status is related to SES factors. 10% is related to our physical environment, where we live, where we work, where we play, our actual zip code. 30% is related to health behaviors. What behaviors? The choices I make with the resources I have in the neighborhood that I live in. And everyone doesn't have the same resources and the opportunity to make the same choices. About 20%, with a breakdown of 10% related to biology and 10% related to clinical care, for 20% total is related to the remainder. So the majority of our health status, almost 50%, is related to the social determinants of health. And specifically, today in 2021, in the United States, zip code is more important than genetic code. In fact, if I was in front of you right now and you told me what your zip code is, I could tell you what your life expectancy would be, what your SES status is, what you're likely to die from, your risk from preterm birth, and the association with stillbirth. That, my friends, is a disparity. I should not be able to tell you that just by virtue of your zip code. And why am I able to tell you that by virtue of your zip code? Because in the United States, even in 2021, we're still very segregated. Zip code is a proxy for segregation, and it is a proxy for health status. Well, why is it a proxy for segregation? Why in 2021 is the United States still so segregated? Southern states have higher risk for stillbirths. Many of our southern states are still very segregated. Why? Because it's that way by design, my friends. It has not happened by accident that we're still so segregated in 2021. We saw this same phenomenon in the United States with the COVID pandemic, where Black and Brown communities were more adversely affected because these are the communities that were still mostly segregated, highly population dense and less likely to be able to remotely socially distance. If you want to know more about redlining and the laws that have been on the books to make sure we stayed this way, please look at the book Color of Law. We have data to show that segregation is related to rates of stillbirth. This retrospective data review from the Consortium on Safe Labor looked at over 50,000 Blacks and almost 72,000 whites from 2002 to 2008. They examined race-specific association between current segregation and stillbirth between Blacks and whites, and persistent segregation between Blacks and whites. They were able to show that low and decreasing levels of segregation over time were more beneficial to Blacks than whites, and that decreasing segregation accounted for approximately 900 prevented stillbirths annually among Blacks. 900, you guys, 900. Their conclusion was that reducing structural racism like segregation could improve health outcomes for Blacks and potentially reduce health disparities. So often when I mention this issue with segregation, people ask me, well, what is the issue, Dr. Kincade? Like me, why? What is the issue with living on the edge of the cliff of good health? What is the issue of these stressors over time? I want to draw your attention to this picture, and I want you to think about the calm before the storm. Often Black women are described as being so calm. We're Black girl magic. We're invincible. We don't have any worries. It's simply just not true. Black women during pregnancy report a greater number of stressors than all other groups. Not that other groups aren't stressed during their pregnancy. We all are. But Black women report a greater number of stressors. And my goodness, isn't there a lot to be stressed about? Racism, hopelessness, poor working conditions, access to health care, lack of access to good nutrition. Things like George Floyd, when stressors happen in the community, they don't just stay in the community. They are transmitted to our families, to the mothers, and ultimately to the fetus. So what does this chronic stress look like? There's a difference between being stressed and stressed out. When you're stressed, your body activates your cortisol response, you neutralize the threat, and the stress should be turned off. But if the stress is never turned off, we know that over time, this chronic elevation of cortisol leads to a weathering process, increasing the risk for chronic disease, especially chronic hypertension, which can lead to so many adverse birth outcomes. So often when I talk about weathering, people will say to me, well, what's the big deal? It's 2021. I mean, really? Are you that stressed? You're a physician. Like, really? Are you that stressed? What do you have to be stressed about? Well, I'm glad you asked. I usually point to my birth story. This is a picture of me as a little girl, 2.5, 3. Aren't I cute? Down here is a timeline of slavery to today. Slavery ended in 1865. Yay. Segregation ended in 1954. Yay. The Civil Rights Act was passed in 1964. So you have 1954 for segregation ending, and you have 1964 for the Civil Rights Act. I was born in 1967. I am from Baton Rouge, Louisiana. I was delivered in Independence, Louisiana at Lally Camp Charity Hospital. You know why? It's the only hospital that colors could deliver. It was the only hospital that colors could deliver. This is a sign from the hospital that I was born at. Monday, OB colored, 8 a.m. to 11 a.m. Gyne colored, 1 p.m. to 4 p.m. Tuesday, medicine white, 8 a.m. to 12 noon. Pediatrics white, 1 p.m. to 3 p.m. I am 53. So it has not been that long ago. Yes, the colored signs came down, colored only signs came down, the white only signs came down, but the policies that put those signs in place did not change. And the people responsible for those policies remained in place. And even today, we still have policies in place that continue to not provide equitable care to persons of color. And we have great evidence to show that Black women who have been hospitalized in institutions during pregnancy, during labor, and still died in hospitals had their concerns ignored. So if I see you and you feel like I'm an angry Black woman because I'm asking questions about my concerns about decreased kicks and you dismiss me, my outcome's just not going to be equitable. And that's how you end up with the little brown girl from Baton Rouge, Louisiana, who has the audacity to go to medical school at UCLA and obtain an MD after being born in a hospital that was still segregated even after 1964. So to summarize, at the very beginning, I mentioned several conditions that we know are associated with racial disparities. We talked about preeclampsia. We talked about chronic hypertension. We talked about lupus. We talked about obesity. We talked about diabetes. We talked about preterm labor. We have very good models to show that chronic cortisol, chronic stress increases the risk for altering our vascular function for the womb, for the uterus, for the cervix. It can trigger preterm labor. We know that it can increase our risk for inflammation. We know that that coupled with the social stresses increases our risk for adverse outcomes, including stillbirth. And we know that chronic hypertension, preeclampsia can both be triggers for placenta abruptia. We know that preeclampsia, chronic hypertension, diabetes, and lupus can all be triggers for preterm labor, which increases our risk for stillbirth. But when we talk about patients who are of color and they're in front of us, we're more likely to blame them for the conditions they find themselves in. So the Institute of Medicine report showed that physicians in the United States are more likely to blame Black patients for the conditions they find themselves in. What does that mean? You have diabetes, you should eat better. You should get fresh fruits and vegetables. You should walk. Have you seen their neighborhood? Have you seen what's available for them to have access for fresh fruits and vegetables? Have you actually walked a mile in their shoes? Think about the cliff of good health, where they are, the choices they have to make with the resources they have. And think about a person like me, for whom SES status 3 degrees is not protective for any of the outcomes that I've just described, and for whom my zip code can predict when I'm most likely to die. So what are my take-home messages for you this morning? You guys, we have to do something different, because you know what? What we've been doing is not working. It's just not working. We need policy change to dismantle systemic racism. We have to be comfortable calling it what it is. And I'm so grateful to Samantha for doing just that when she introduced my session. We need education for healthcare providers, especially in areas with the greatest disparities. I'm originally from Baton Rouge, Louisiana. I live in Texas. I can tell you for sure, we still have a lot of work to do. We have to empower our patients with knowledge. I personally believe that things are not going to change significantly until all our moms are empowered to be able to come in and advocate for themselves. In order to do that, we have to talk about counting the kicks. We have to talk about the prior losses. We have to talk about the relationships for the conditions that trigger stillbirth. We have to think outside of the box. What does that look like? We have to partner with our community partners and stakeholders. And we have to think about having people at the table who look like the communities we serve. You know why? Because many of our communities don't even trust our healthcare systems anymore. We need to partner with our doulas and our midwives. We need to normalize mental health for Black women. We have to. We're not invincible, and this is not a Wakanda forever type situation. We have to normalize mental health. We need our community stakeholders. We need our faith-based organizations. We have got to have improved infrastructure in our low resource community. And we have to have a day when every space is designated as a perinatal safe spot. Thank you so much for your attention this morning. I hope you've been able to take home a few take-home points. If there were questions I wasn't able to address, please feel free to email me. I want to give a shout out to PLIDA, Pregnancy Loss and Infant Death Alliance, which is looking for evidence-based interventions, particularly for marginalized communities, and to Return to Zero Hope, which is doing so much great work to remove the culture of silence, particularly in marginalized communities with respect to neonatal loss. Thank you so much for the opportunity. I really appreciate it.
Thank you so much, Dr. Terri, for that incredibly illuminating, disturbing, and powerful, very powerful presentation. You know, I just think it's so important that we actually speak the words. Black lives matter. Black mamas matter. Black babies matter. And until we can all get behind that sentiment 100%, we are not going to see change in this country. So thank you for all you're doing to raise awareness and to improve education so that we can combat this huge problem together.